Hello everyone, welcome back to the continuation of question paper discussion public health dentistry. We are into part 5. So this part includes pit and fissure sealants, Atraumatic restorative treatment, survey procedures, planning and evaluation, finally the dental indices. Out of these 5 topics, survey procedures are very important. The question long essay, every 2 years the long essay will be a survey procedure. It is nothing but an extension of epidemiology. The way we conduct a survey, the steps in survey are the important thing in survey procedures. Epidemiology is nothing but how to scientifically conduct a study to control a disease, the study the disease and control the same disease, whereas survey is nothing but the collection of data using any method. So survey is a part of epidemiology also, because epidemiological studies are observational, experimental, so in all methods we can apply survey. So survey is just but collection of data using any methods. So we'll start with pit and fissure sealants. It's very easy topic. Usually short essay or short note will be asked from this chapter. So we know it is to seal the pits and fissures so that it will act as a protective layer which prevents the access of, or which blocks the access of caries producing bacteria from the source of nutrients. And we have classification of pit and fissure sealants. It is not the pit and fissures. Pit and fissures are I type, U type, V type, K type. They are classification of fissures, but this is about the sealants. The most common classification is based on polymerization method, that is first to fourth generation. First generation is based on UV light, then self-cure or chemical one, then the visible light, and fourth generation is fluoride releasing. We have resin system, that is BIS-GMA and urethane acrylate, and depending on the presence of filler, filled and semi-filled, and depending on the color, clear and tinted. So steps are very easy to write. You just need to imagine the procedure in any composite restoration. So it is like cleaning the tooth, isolation, enamel etching, application of sealant, curing, inspection, reevaluation, cleansing, and the final polishing using APMS and water. Now we have a short note which is known as preventive resin restoration. So the pit and fissure sealant is actually not a restoration, it is a sealant. It is a non-invasive procedure. We are doing it on a natural tooth, which is likely to have a caries in a future period. So we are cutting the risk. But preventive resin restoration is a restoration. So it is the minimal approach compared to the conventional amalgam. So this resin is placed in caries area and seal it from the oral environment. So we have 3 types: type A, type B, and type C. Type A, it comprises just deep pits and fissures, so caries is limited to enamel. So we can create a simple small preparation and use a unfilled resin or sealant. Whereas type B is little more deep, so we need to restore with some filler, because it needs more power, because the material has to withstand the occlusal forces, so we add resin with a filler. Whereas type C is very deep, so we might need to add a base for that, because it is reaching to dentine. So resin layer followed by the composite should be used as for the restoration. So the same steps you can write: prophylaxis, isolation, then acid etching, washing, drying, and all the restoration. Next is the most important short note, atraumatic restorative treatment. This was started by Jo Franken in 2012. It is a minimally invasive approach to prevent dental caries and stopping its further progression. So, two basic principles are there. The first one is using hand instruments, because it was started in areas where the electricity was not available. So the first principle, using hand instruments. Second is using material which sticks to the tooth, that is a chemical bonding. So we use commonly GIC because we don't have curing light, and we cannot use amalgam because it needs extensive cavity cutting. So we can use it without electricity and without much equipment. So it has to be naturally, chemically bonding to the tooth structure. So GIS is the most apt one. So these are the two principles. Now let's see what are the indications. So it's commonly used in small cavities and which are accessible by hand instrument, and most commonly this is a method public health programs adopts. But if it is deep cavity with swelling, fistula or pulp exposed, we cannot use it. Advantages, it's a biological approach which has less trauma, and it can be practiced anywhere with simple infection control, and it is very cost effective. So these are the instruments we need to use for ART, that is mouth mirror, explorer, tweezer. The main thing is spoon, excavator and hatchet, carver, mixing pad and spatula. So procedure is same for everyone, for PRR and everything. Only thing is we don't apply etchant and all, rest all are same. Arrange a good working environment, hygiene control, caries removal, conditioning, mixing and restoring the cavity. Now we are into the most important chapter, that is the survey procedures. So the question will be like this: define survey, discuss the details of various steps, and sometimes an additional question of Pathfinder survey and index age group will be there. So survey is nothing but an investigation in which the information is systematically collected. So this is the key part where the information will be collected without any experimental method. So survey is anything which collects information is a survey. It can be a descriptive study, can be analytical study, like case control, cohort. Even we take information in the experimental study, public opinion surveys. So everything is survey. So these are the steps. You need to elaborate about these steps, that is establishing the objectives, then designing the investigation, then selecting sample, that is most crucial part. After that, conducting examination, then we need to analyze the data. After that, reaching to a conclusion, and finally we are publishing the result. So these 7 steps you need to write. After that you can write little bit about each step. That is the step 1, which is the establishing the objectives. So it means the investigator, he must be absolutely clear about the objective of investigation. Okay, it can be either started in the form of a hypothesis which is to be tested, or objective maybe stated by describing what is to be measured. So the starting point of a study is an expression of a null hypothesis that says that there is no effect, or there is no relationship between two things which we are going to test. The second thing is designing the investigation. We can opt a descriptive study or analytical study. So that is the second part. Third part is selecting sample. So we can select the sample using any sampling technique. Okay, so that is coming in next slides. Then we need to conduct the examination using our instruments. Then we have analyzing the data using statistical method and drawing to a conclusion, and finally publishing the result. Okay, the second question, this is very important. Sometimes the survey procedures will be along with this Pathfinder survey. So Pathfinder survey is a method to collect data, and it uses stratified cluster sampling, and it includes most important population subgroup. It has two types. One is pilot and pilot Pathfinder, then there is national Pathfinder. So pilot survey, which includes only 1 or 2 index age groups, usually 12 years, or one other age group, and it is a pilot survey, so it is having minimal data. Whereas a national Pathfinder survey, it includes most of the population subgroup. It includes 3 of the age groups. The age groups we are going to see in next slides, which is actually suitable for planning and monitoring. Okay, this is suitable for to commence the planning. Okay, then sampling sites usually chosen so as to provide information on population groups likely to have different levels of oral disease. So we need to take samples from cities, small towns, and including all ethnic groups. So this is the index age group I was talking about. We have 5 index age group. One is 5 year, then 12 year, 15 year, 35 to 45, 44, and 65 to 74. So 5 year is the age of interest in relation to KUHS level in primary dentition. This 5 year is important because it is the age at which children begin the primary school. Okay, then 12 year is important because it is generally at which children leave primary school and is the last age at which a sample may be obtained easily through the school system. So it is also known as a global indicator age group for dental caries. In 15 years, it is the age where the permanent teeth have been exposed to oral environment for 3 to 9 years. And this is also important for the assessment of periodontal disease indicators in adolescents. And 35 to 44 year is a standard monitoring group for health condition of adults. So full effect of dental caries, the level of severe periodontal disease, all can be monitored. 65 to 74 year, this age group has become more important with the changes in age distribution and increases in lifespan that are occurring. Data for this group are needed for both planning appropriate care for the elder group. So these 5 are the index age group. Okay, so now we are into the sampling method. We have basically 2 types of sampling: probability and non-probability. Probability means it's difficult to conduct, but it is the ideal one because it ensures each participant's probability to be in the study. Okay, so if 100 participants are there and we are going to take 10 out of this 100, all 100 participants have equal chance of being that sample or being that 10, but ultimately we take only 10, but still that chance is there. But in non-probability, that chance is not there. So 100 students and we are taking 10, not every student has a chance to be in the study because it is non-probability sampling. So let's see one by one. Simple random, the application is small, homogeneous. So what is happening here is it is now commonly done by lottery system and table of random numbers. So this is how it is. We randomly pick 3 out of this 16. We randomly pick. So all 16 members have equal chance. Okay. So this is the most ideal method of sampling, simple random sampling. So we just put all the 16 into a jar and we just take 3 out of it. Whereas systematic sampling will be done in a sequence. Okay, so the sequence is known as sampling interval. So it jumps from one person to the sequence, following that sequence. So in order to find out the sequence, that is a sampling interval, we have to apply the formula, that is total population by sample size. So we are going to select 5 people from 15 people. Okay, so 15 by 5 is 3. Okay, so we need to select in a sequence of 3. So what we do is we randomly pick one person. Okay, So we select the second person as a starting point. Then we jump to the fifth person, that is we are maintaining a 3 sampling interval. Then we jump to the 8th, then we jump to the 11th, then we jump to the 14th. So if we finally get the required sample size, that is 5. So first, in the beginning, we need to find out the sequence. Okay, that is sampling interval, total population by sample size. This is just a diagrammatic representation. So sampling interval we need to find out. That is total population. We have 15 people and sample size required is 5. So 15 by 5 we get 3. So 3 we can start from any person. We can start from one person, second person or third person. Okay. So we cannot start from fourth person, because if we start from fourth person, what happens is we will not reach the fifth person, because 4, then 7, 10, 13, then we don't have the 16th person. So we need to start from 1, 2nd or 3rd, because 3 is our sampling interval. So 1st, 2nd or 3rd, we can start from any person. So usually it will be random sampling. So we will do random sampling for these 3. So from which sample to be started. So sometimes if it starts from 1, then we follow the 1, 4, 7, 10 and 13. If we starting from here, 2, 5, 8, 11 and 14. If we are starting from third person, 3, 6, 9, 12 and 15. So sampling interval is used for systematic sampling, whereas stratified sampling, sometimes the population will be heterogeneous. There will be males, females, sometimes it will be kids, teenagers, adult population. So what we do is, first we make them into strata. This is suppose adult people, this is teenage people, this is kids, and from each population we randomly select people. Okay, so this is random sampling. So in probability sampling, the random sampling, this simple random is a basic level or basic sampling, is done in all sampling method. So it ensures the equality. It ensures each participant's probability to be in the study. That is stratified sampling. Now we have cluster sampling. When we have big town or big district, what we do is, first we make geographical clusters. Okay, geographical clusters we make, and from these clusters we randomly pick few clusters. That is, we have selected maybe cluster 1 from this, cluster 5 from this and cluster 6 from this. So random sampling must be done at one point of time. So first we need to make it as a cluster, and this is multi-stage sampling. So this is usually in a big population like a country or a state. What we do is, first we select 25 districts of a state. Then we select 10 districts out of 25 from random sampling. Then from this 10 district we divide into boys secondary school and girls secondary school. Okay, so here we do stratified sampling, and from this we do random sampling, and here also we do random sampling. So random sampling and also stratified sampling, and finally we reach 402 secondary school heads. So it is reducing the number of samples to the desired level, but maintaining the probability sampling at all points. Sometimes we will be following simple random sampling. From 10 district we selecting this girls and boys. From that we have done stratified random sampling, and third stage again we have done simple random sampling. So it is multi-stage sampling. Okay, so here 10 districts were selected by simple random sampling, here this selected by stratified, and here also is selected by simple random. Now non-probability sampling, here the participants is not having any chance of being the study. because non-probability convenience sampling. So my convenience is only this part of people, so I just select this group. So these many group of people lost the chance of being in the study because we are not doing any probability sampling. Here it is just convenience. So convenience is mostly done for the convenience of the researcher. So if he is starting a study which includes many panchayats or many villages, so he'll just go to the nearby village because that is convenient for him. So the other village people lost the chance to be in the study. So it is not a good sampling method, but this is most commonly followed. Quota sampling is we can compare it with our stratified sampling. Here what we do is we select quota and we select participants just like that. In a classroom where we have 50 students are male and 50 students are females, in stratified sampling, if suppose we want to take 5 from each group, we do simple random in 50 and we take 5. But in quota sampling, we just take 5%. Any 5 people will be taking without any random sampling. So it is only difference, there is no random sampling here. Judgmental or purposive sampling, both are same. So it is like a fashion manufacturer use a sample of big customers because he is very judgmental about the population. He knows that for him it is good to conduct a survey in a big customers. So he'll do the customers only. He'll do the sample from only big customers. So only include those who have traveled overseas for the past 2 years. So being judgmental about the sample or being taking sample just for the purpose. So that is purposive sampling. And snowball sampling, it is a very tricky sampling. Snowball sampling, the name it got because when we roll a snowball from the top of the mountain, as it goes downward, it will fetch the ice particles over the track and it will start increasing its size. That is why it's known as snowball sampling. When it goes forward, it collects all the ice particles where it gets contacted with, then it starts increasing its size. So when a small ice ball we started rolling from the top of the mountain, once it's reached the bottom, it will be a bigger one. Similarly, studies which involves privacy, like homosexuals or the diseases which a person is very reluctant to reveal. So in those cases where we want to study in those conditions, what we do is we select one person and ask that person to search for 2 other subjects, and from each person we ask the same. He must get 1 or 2 other patients or other similar sample, so that their identity or anonymity can be maintained and there is no problems for the participants. Their identity will be kept confidential. So that is snowball sampling. It's a little difficult to conduct. Now we have an exam question, that is training and calibration. So training and calibration is nothing but standardizing and calibrating the examiners who are ready for the examination. So we must make sure that our examiners are very reliable. There should not be changes between the examiners. That is, one person might be knowing the criteria as well, but the other person will not be knowing the criteria. So that will create lots of problem. So we must ensure both the examiners are well known about the criteria. So for that we need to train and we need to calibrate the examiners. So that is usually done using capacity statistics. So once they are standardized about the procedure, diagnosis, or the methods, we give them pilot study. So that same person will be taking 5 patients at different point of time, and he needs to report the same uh, values. Like DMFT we are taking 5 people, 5 subjects will be measured by the same person, and he must report the same DMFT values at both different point of time. So usually if he takes 10 patient, he must report the same value for at least 8 patient. Just an example hypothetically. So that how we calculate the KUHS statistics, that is a reliability or the agreement. Intra-examiner reliability is the same person must report the uh, same result, or the consistency should be there. So that will be assessed using this KUHS statistics. Usually it should be around 0.8. Then only we can allow the person for the main study. Whereas inter-examiner reliability is a little different. When we have more than one person, both the examiners should do the measurement on same patients, and both the examiners should report same result. There also we do this KUHS statistics, and it should be more than 0.8. So for that question, training and calibration, you need to highlight the KUHS statistics and examiner training and calibration. Now we have another question, that is types of examination. So this is types of oral examination. We have 4 types, type 1 to 4. Type 1 is complete examination. It can be done at a college, it can be done at a clinic, where we have everything, that is mouth mirror, radiography, pulp vitality test, study models, laboratory test, everything is readily available. Whereas type 2 is limited examination. We have mouth mirror explorer with light with radiograph. It can be used in a surveys. Whereas type 3 inspection, it is only mouth mirror and explorer with light is there. It can be done in public health surveys. Whereas this type 2 for the combination of public health program to individual patients with population survey. Whereas type 4 is just tongue depressor and illumination. So this is this method identifies individuals in urgent need of treatment. Okay, it is the unreliable for most public health survey. Now we have planning and evaluation chapter. Most commonly asked, define evaluation and the steps in evaluation. So evaluation is nothing but a process of determining the value of something, or to the extent which goals are being achieved. 2 types we have, formative and summative evaluation. So the first classification of evaluation is summative and formative. Summative is at the end of the learning period. Formative is during the process of learning period. Can give you an example. Our first, second and third internal exams are formative evaluation, and your university examination is summative evaluation. So we can follow the remaining with the example of these. That is the purpose of assessment of university examination or summative is to measure the competency, whether you are ready for checking patient or not, to determine how well the students can do relative to a given concept or skill. Whereas a formative evaluation, that is the internals, is to improve the instructions or improve your performance. Use of result, university examination or summative evaluation to give grades. Whereas formative evaluation, it can be lesson for teachers to plan and modify the instructions. For student, if is not performing well in first internal or second internal, he must do well in third internal to get the good marks. So formative evaluation is for improvement, but summative evaluation is for grades. So the example, summative is end course result or public exam or university exam, whereas a formative is your internal. So it's very easy if you remember in this type. And there are many other types of evaluation, that is types of evaluation. We have criteria evaluation, impact evaluation, relevance evaluation, process effectiveness evaluation, efficiency evaluation are there. But these two, summative and formative, are mainly important, and some steps are there for evaluation that is asked. So I forgot to mention here, so I'll add here. That is general steps. First we need to determine what is to be evaluated, then establish standards and criteria, then plan the methodology to be applied, gather information, analyze the result, take action, and re-evaluate. So these are the steps of evaluation. Okay. Now we have the planning cycle. It was asked once. So planning, we have steps of planning. That is, first we need to identify the problem. What is there? High dental caries prevalence in a city. First we need to do a needs assessment, then collect the data using survey. Then we need to analyze the data, and we need to determine the priorities where we have to apply the program, mostly school children or women's. And we need to develop goals, objectives. Goal is a broad statement. Objectives are the measures to achieve the goal. Then we need to find out the resources, the workforce, time, money. So all type of resources we need to find out. Then we need to check for the constraints. What are the problems? The money problem, the workforce problem, time problem. So we need to have a backup plan. Then from out of this we need to select a plan which is very effective. Then we need to implement, then monitor, finally evaluate. So there are a few types of health planning. First one, this is asked once, types of planning. So we have problem solving planning, then program planning. Problem solving is like fluorosis in a community. Then program planning, that is school based fluoride rinse program. Then coordination of efforts and activities planning, that is closing of obstetrics pediatric wards in an area where the birth rate is very declining, and planning for allocation of resources, that is fluoride mouth rinse program is getting replaced by sealant program, so we need to do planning. So this was asked once, types of planning. Okay, so planning cycle we need to elaborate in your own points, but you need to maintain this flowchart. So evaluation, steps of evaluation is there, and other types are also there. Now we are into the last chapter, that is indices in dental lipidology. It's not very commonly asked, but it is asked sometimes. So this question is asked, that is ideal characteristics and describing or defining. Index is a numerical value describing the relative status of a population on a graduated scale with definite upper and lower limit, which is designed to permit and facilitate comparison with other population classified by the same criterion method. When you write definition, you must write from the first word to last word. You cannot replace a preposition also. So ideal requisites, it should be simple, clear, it should be objective, that is investigator should decide what it is there. The subjective interpretation can't be accepted. It should be valid, it should be sensitive, it should be specific, it should be reliable, it should be acceptable and quantifiable. Need to little bit explain about all this. Russell index is commonly asked. We know Russell index for a periodontal index given by Russell. It has got 6 codes, 0, 1, 2, 4, 6 and 8. 0 is negative, 1 is mild gingivitis, 2 gingivitis. 4 is used only for radiograph, 6 is pocket formation, and 8 is close of masticatory function. Next periodontal index is CPITN, which was given by WHO and FDA in 1982. The mouth is divided into 6 parts and using a WHO probe. So this CPITN was introduced by this Juka Enamo for Joint Working Committee on WHO and FDA in 1982. Okay. So this teeth examined are 6 quadrant and index teeth 11 or 21, 16, 17, 26, 27, 31, 41, 46 and 36. Sorry, I missed 36 and 37. So 6 quadrant are there. So these are the chords. This is CPI chords and this is treatment chords. 0, 1, 2, 3, 4, X and 9 are the CPI chords. 1 is bleeding, 2 is calculus, 3, 4 are the pockets, where 3 is black band of the probe is visible and 6 is not visible. Treatment needs, we have 0 treatment, 1 self-care, 2 is for professional scaling, 3 root planing, and 4 complex therapy. Whereas CPI and loss of attachment, because treatment need index, CPI TN index was overestimated. So what in 1994 WHO replaced this treatment need part. So this part is replaced using a loss of attachment, because so in Russell index also what happened was this is very overestimated, because actual sign of periodontal disease is loss of attachment, that is nowhere mentioning in Russell index. So CPITN also nowhere mentioning the loss of attachment. So CPI is CPITN, where the treatment need is replaced by loss of attachment index by WHO in 1994. Okay, so here the CPI codes are same, but the loss of attachment codes been added. Here 1, 2, 3 are loss of attachment. 4 to 5 mm, that is CEJ. It is measured from CEJ to the bottom of sulcus, whereas the CPI code is measured from gingival margin to the bottom of sulcus. Okay, this is gingival margin to bottom of sulcus. This is CEJ to bottom of sulcus. So two criteria should be there. Either it can be measured. This loss of attachment can be measured if the CPI code is 4. Otherwise, there should be loss of attachment. Only in those two criteria we need to check CPI codes. If the CJ is not visible and the CPI score is 4, or otherwise if the CJ is visible, that means recession is present. So 0, 1, 2, 3, 4, X and 9 similarly, but the one also is not like that. One is like 4 to 5 mm loss of attachment. So it's very difficult to see loss of attachment 3, 4, because 3 means it will be already grade 3 mobile. So we get loss of attachment mainly for 50 plus patients, I mean age group. This oral hygiene index is very simple, given by John C. Green and Draca-Vermeulen. It has got two components, debris index and calculus index. We have code 0, 1, 2, 3, that is less than 1/3, less than 2/3, and more than 2/3. And for debris index, stains are also present. So stains means definitely it is 1 irrespective of the surface area. Calculus also same 0, 1, 2, 3, but only thing is in 2 and 3 subgingival calculus is coming. So 2 means individual flex, 3 means the heavy band of subgingival calculus, and we add the score, debris index and calculus index. So this is how we calculate 6 teeth, index teeth. Why it is index teeth? Because it is the first tooth to be erupted in that quadrant. 1, 6, 1, 1, 2, 6, 3, 6, 3, 1 and 4, 6, and we use lingual surface of 3, 6 and 4, 6, and we calculate it, and we get interpretation good, fair, poor. For debris index and calculus index individually we have 0 to 0.6 good, 0.7 to 1.8 fair, 1.9 to 3 poor. For the OHI score, that is the addition of these two, 0 to 1.2, 1.3 to 3, and 3.1 to 6. Okay. And the instruments we use is Mothman and number 23 Explorer, that is oral hygiene index. Now we have DMFT index. It was introduced by Henry Klein, Carolee Palmer, and Hudson J.W. in 1938, where we calculate decayed, missing, and filling tooth. So DMFT is 28, whereas DMFS is 128. If third molars are included, it will be 148. So we have 28 teeth or 32 teeth. So it is decay will be written as D, and missing will be written only if it is missing due to caries, and if it is only filled due to caries will be considered, otherwise it will be empty. Okay, and finally we add up all this DMF. In DMFS, what happens is the canine to canine teeth will be divided into 4 surfaces: buccal, lingual, mesial, and distal, and the premolar to molar will be divided into 5 surfaces. There is an addition of 1 occlusal surface, and we have 2 modifications, 1987 and 1997 modification. because the main problem is we are considering filling and missing only due to caries, and we know that the missing and filling could be due to many other reasons. Missing due to ortho reason, missing due to trauma, missing due to periodontal disease. It's not considered in 1938 criteria, and filling also not considered. Preventive filling is not considered. Caries abrasion, abrasion filling, trauma filling, nothing is considered. So later on it is modified by WHO in 1987. Third molars are also not considered in 1938. So 87 modification, 3 modifications are there. Third molars are considered. Temporary restorations are considered as D, and initial caries are excluded. So in 38 criteria, it is very easy to make it as a caries. Just a catch means we make it as caries. 1997 criteria where we use a CPI Pro. So that was about DMFT index, and one more index. There might be a question of Dean's fluorosis index that we already seen in our fluoride chapter. So that was all about this session. This was about indices, survey procedure, planning and evaluation, and the first 2 chapters, that is ART, pit and fissure sealants, and PRR. So next session is the 6th session. We have one more session. 7 sessions will be there. So 6th session is about healthcare delivery system, dental auxiliary, finance in dental care, and research methodology. And there will be one more session. So we have now made it into 7 parts because there were some another questions being added up. So let's make it a 7 part series. So I'll come with this part 6 in my next session. So hope you must have watched all the 5 parts. If not, start from the first session. So it is, as I said, it is a quick review, not a replacement for your preparation. I don't suggest it is a replacement. You can use it as a adjunct for your preparation. It will be like a quick review. Once you have prepared well, you can go through all these. You will get a better overall view of all questions and answers. So always use it as a quick review. I will come with this part 6 in my next session. Thank you.